The next part, we're looking at driving recovery of function through neuroplasticity. So we're looking specifically at the brain and at those motor map areas that we showed you in the homunculus earlier. Some of the factors that influence the functional recovery typically happen in two specific stages. So the first stage is known as spontaneous recovery, which happens in the first 3 to 6 months. And it's really related to changes in vascular supply, metabolic, and neurologic factors. And in this period, it initially goes through 2 phases. The first phase is known as diastasis reversal, which is nothing more than having a period in which the brain was in a sleep mode directly after the insult, and has now started to take stock of the damage that has occurred, and slowly starts the process of increasing new blood vessels, starting to get new nerves working, and reconnecting or reestablishing neural networks or connections between the neurons. And like I said, this stage really happens within the first 3 to 6 months. The second stage is primarily known as training-induced recovery, which is typically any time between 6 months and onwards onto infinity. This really is related to central nervous system plasticity, meaning what you train, how you recruit the muscles, and continuously retrain and work those muscles. Ultimately, you're able to start learning and establishing new neural networks. It happens primarily, like I said, after the 6 months, and it is very dependent upon external stimuli and behaviors that are placed upon the central nervous system. So what we're able to see when we're starting to work on the neuroplasticity is that the distribution of your motor cortex does change. And those motor maps are able to actually retract or extend into neighboring territories of the homunculus. So if you can remember looking at the gentleman with that left MCA CVA, he's not able to use his hand or his arm. So those areas for his right side of the body are not being used. But this, on the left side or the left hemisphere of his body, he's then able to actually start to use or incorporate more activity on the left side of the hemisphere. Whereas for the right side, it slowly starts to lose the ability to do what it was looking for. Ultimately, we have to remember that it is a highly competitive process. So if you're not going to use it, you will lose it. And whatever you're training can either be a positive or a negative, but it is ultimately heavily influenced by the way you're training. We also want to look specifically at the mechanisms of recovery. So recovery, initially in the first 3 to 6 months, we're really looking at the restoration of the neural tissues, the restoration of your normal movement, and then ultimately the restoration of your activity to your prior level of function. This is really where your inpatient acute rehab comes into practice. We really want to make sure that we're paying attention to helping the patient reestablish the connections and networks that they used to have to get back to being able to recruiting the muscles the way they normally used to do. In the event, once you start to get closer towards the end of your 6-month period and you're having difficulties still not being able to do your regular tasks such as transferring in and out of a chair or bed, or even just moving around and starting to stand and walk, you're then going to start to move on towards the second stage of recovery, which is compensation. And in this stage, you're really working on recruitment of new neural circuits, developing new movement strategies, and ultimately new ways of performing an activity. So we're starting to get sort of modifications or adaptations to doing the same task, but in a slightly different way than what normally would happen. What you are starting to see within the brain at this time when we're working those new neural circuits is that you're actually able to see some of the changes in the territory once you're learning a new skill. However, that skill and those changes is highly dependent upon how you're training the specific task. So if you want your hand to start working more, scientists have noticed that its greater recovery is most likely going to happen if you're working an entire activity. So reaching for a cup or kicking a ball, you're more likely to see improvements rather than if you just practice the movement or the hand motion in isolation. For a skill acquisition, You also want to get mini repetitions with a progressive level of challenge. You want to allow primarily for successes, but you also want to have some failures in order for your patient to learn from some of the mistakes that they've got. Next thing that you want to look at is really the structural changes that you're starting to see inside the brain. So what we've noticed with mass practice, meaning lots and lots of practice within a session, you're starting to see an increase in the dendritic tree, which makes it easier to excite a neuron. The more easy it is, the more likely you are able to actually get those neural circuits working and be able to establish that new movement pattern. With that too, you're then starting to see long-term potentiation and long-term depression. So you're getting changes in excitability of the pathways that depend on repetition, and you ultimately are going to get new movements patterns that are forming. You just essentially, the more you work the circuit, the more neurons you're able to have within the vicinity that you're working. And the more neurons you have, the greater ability you ultimately are going to have to potentially get those neural circuits working for that new movement. Some of the trends in recovery that we have seen, though, is really specifically looking at ambulation. What research has shown, which I know it's very difficult to actually get a prognosis for this, because it's just so variant upon patient population, is that 30 to 40% of patients can actually walk independently at the onset of their symptoms of their stroke. However, of those 30 that can walk initially, 33% of them will die. And the remaining 50% will likely ambulate after intense rehab. Some people, even after going to intense rehab, are just not going to be able to walk, just as an extent of the amount of damage that they've had. What we do know, though, is that 90% of the recovery of both legs will occur within the first 3 months, and then it should recover completely within the first 6 to 12 months. Even if patients are not able to recover, however, we have seen that even patients chronically after 5+ years, if they're constantly working the entire circuit, you're able to see some changes in their ability to ambulate. Whether it's with compensation or adaptations, we're still getting improvements that we wouldn't normally anticipate. And that, once again, is primarily due to neuroplastic changes of the brain. Trends in recovery for paresis. We have seen functional recovery, though, is highly related to some of the initial deficits in motor function and tone. So tone, once again, just because it often comes up with this patient population, is an increase in the muscle excitability, and it's typically an abnormal increase in excitability. So you don't really want those muscles to work. You don't want to bend your arm, but those muscles are excited and nothing really stops them off. So there's no inhibitory motion for that. What we have seen, though, is that arms will most likely regain functional movement within the first 48 hours, and you should see marked to almost full improvement within the first week. Some patients will still have residual tone or a flicker of motor output or abnormal deep tendon reflexes, but for the most part, they should have functional movement arms. And then at least 2/3 of good recoveries, whatever that may be to you, basically just being able to use the hand, should occur within 4 weeks after the insult of injury. But once again, too, we have also seen that even 10 years after your initial insult, we have shown some good recovery, but it is, once again, heavily dependent upon how you're training. So keep on working, make it task specific, make those muscles work, and always incorporate the arm or the leg into whatever task you're using, because if you don't use it, you will lose it.